This program is made possible in part by Cerisi Conlon LLP, protecting the future and using the law as a force for good in both the courtroom and our communities. Online at cerisiconlon.com.
Hello and welcome. I'm pleased to introduce my guest to you tonight. Dr. Amy Maltry is with me, and she is an ophthalmologist at the Southdale Eye Clinic here in the Twin Cities. For years and years, I've gone to eye doctors, of course, and I've realized that I don't know as much as I should about my eyes, and in spite of going regularly, and I'm guessing that most people don't. And so I think you're going to really learn from this interview from Dr. Maltry. And I also want to really ask her a lot of questions about things we can do to take better care of our eyes in the preventative mode. So we'll get to that, I hope, fairly soon. But first, let me introduce you to Amy, Dr. Maltry. Welcome to the show.
Yeah. Hi, Mary. Thank you very much for having me.
Of course. You've had some neat honors at the University of Minnesota where you've taught. You were voted, I want to get this right here, Best Teaching Faculty in the Surgical Teacher of the Year by the residents in the Ophthalmology Department at the U of M. And that's from your peers and people who know the world you're in. That's a great honor.
I love teaching. I think it keeps me sharp, having to work with these residents and trainees who are learning, and they ask all the great questions, and I just have to make sure that I know the answers as well. So I really get to enjoy working with them and having that as part of my job.
And you not only do some teaching, and of course the work with regular patients at Southdale Eye Clinic, but you also do some research, and you're working with the Vets Hospital too, correct?
Yeah, so I have a really great variety in my career. So I do comprehensive ophthalmology and see patients on a daily basis at the Southdale Eye Clinic, but I also spend time doing academic work at the university, and then about a day a month I go over to the Veterans Hospital and work with the residents, teaching them surgery as well, largely cataract surgery.
So all kinds of tasks, every day is different, I bet.
Yep.
I want to start out with just a really basic question. I realize that a lot of friends and people I know are not quite sure the difference between what your specialty is, ophthalmology, and an optometrist. So let's get that cleared up right away.
Yeah, I think that's a wonderful question. So ophthalmologists and optometrists colloquially are both known as eye doctors, but our training is different. So optometrists go to optometry school, get their optometry degree, and then go out and practice, whereas ophthalmologists are medical doctors, so they get either an MD or a DO degree, so they go to medical school and then specialize, doing further residency and sometimes fellowship training in medical diseases of eye care. And really, I think we both types of doctors have our role in taking care of patients. Optometrists do a lot of primary eye care, glasses, contact lenses, and really excel at that. And ophthalmologists do more medical treatment of eye disease as well as surgery and laser. So we're just kind of coming at eye disease from different directions, and we really are a team working together.
We
to
need
take our
teams
best
in our
care.
medical world, don't we? Maybe now more than ever. But the ophthalmologist has how many years under your belt as a a student?
Yeah, so you're 4 years of college, 4 years of medical school, 4 years of residency, and then oftentimes 1 to 2 years of fellowship after that. So you're looking at 12 to 14 years
Yeah, I'm counting
of
here,
schooling.
going, oh my
Yeah.
goodness, that's a lot of years in
Yeah.
advanced degree work. Well, the most common eye conditions and diseases that you see as ophthalmologist, what would they be if you list the top 4 probably?
Yeah, so most common, I always tell people the kind of big 3 really are cataracts, glaucoma, and macular degeneration. And then for me, refractive error, which just means glasses and glasses correction, I
Okay.
would say are by far the main things that I help take care of.
What about diabetics who've got the retinopathy? Is that in terms of numbers of people, is that up there too?
Yeah, so I screen a lot of patients for diabetic retinopathy. So essentially every patient that gets diagnosed with diabetes should have an eye exam every year. And it should be an exam where they get their eyes dilated so we can take a look at the entire retina. So I see a lot of patients who are getting their screening exams for diabetic retinopathy. I help take care of patients with kind of early onset or more mild to moderate. If it does get more severe, then we usually refer people to see a retina specialist because they might need more advanced treatment for their disease.
And just one more question about that in terms of this disease. Is it both diabetes 1 and 2 that are prone to getting retinopathy?
Yes,
Okay,
so either type 1 diabetes or type 2 diabetes can get diabetic retinopathy.
Okay.
And the most important thing that I tell people is best thing they can do for their eyes is have good blood sugars, and that applies to either type of diabetes. So if their blood sugar is at the target that's set usually by their primary care doctor, typically their eyes do very well. If they struggle to keep their blood sugars under control, then that might be reflected in their eye exam.
So you can use that as a motivating factor, can't you, with diabetic?
Yeah.
Keep the numbers down. Well, let's talk cataracts first. You do cataract surgery. I've had cataracts now and have had surgery. It's much more complicated in terms of choices patients make. It's just not one size fits all, is it?
Yeah. So cataracts are one of the most common things I see because getting cataract is normal. It's one of those things where if you live long enough, you get some.
So everybody will
So
eventually?
everyone eventually gets a cataract.
That's the bad news, folks.
Yeah. And the good news, though, is that not everyone needs surgery for it. If the cataract is cloudiness of the natural lens inside the eye, and if the cataract gets cloudy to the point where it bothers the vision and I can't get people seeing well with glasses, that's when surgery can be helpful. And what we do in surgery is remove the cloudiness, which is kind of in the middle part of the lens. When that gets removed, you're really taking away the ability of the natural lens to focus light anymore. So we replace that with a clear implant lens that does the job to focus light. And that's where all those choices come into play, really.
With that implant lens. This sounds, if you haven't had to deal with this yet, like this would be major surgery that would take hours. However, tell the viewers how long it takes.
Yeah, so cataract surgery is very elegant surgery, typically less than 15 minutes.
It's so kind of amazing to hear that when I first heard it, 15 minutes for surgery. I mean, that also, I'm guessing, relaxes your patients a great deal.
Yeah, I always tell them that sort of 15 minutes for the actual procedure, which means for a lot of the time, you know, they get a little bit of relaxation medication, but they're a little bit aware of what's happening around them, and people do great with that.
Do they? Okay.
Yeah. And find it to be typically nerve-wracking beforehand, which I say is very normal to feel anxious about having a procedure done on your eye. But once it's done, typically patients get to the end and they say, oh, that wasn't that bad at all.
Right. That's what I hear from friends and the doctors, of course. And do people usually, if you get cataract in one eye that needs surgery, do you usually have to do the other eye also? Or can there be one-eyed cataract people?
Yeah. Oftentimes people's eyes, the cataract will develop symmetrically, so they might have both eyes ready at the same time, but not always. Sometimes one eye will be cloudier than the other, and they'll have more trouble with the vision in one eye and no trouble with the other. And in those cases, typically I'll just do surgery on the eye that's the problem. And then I tell people they're going to fall in one of two camps. We'll do one eye, and then they'll say, oh my goodness, the vision is so much better. Now my other eye bothers me, and then we'll do it.
And they hadn't realized maybe the lacking of what they could have.
Yep, exactly. So it's all relative sometimes. Or they might be the person that says, yeah, you know, that one surgery fixed my problem, and then we just watch the other eye over time and see if it becomes a problem later.
That's good to know. But as I understand what you're saying, Amy, there's no way to really prevent cataracts from developing?
Not necessarily, no. There are ways to maybe slow the progression. One of those ways is to wear UV light protection over the eyes.
You know, and you mean in terms of your sunglass choice?
Yes. So either sunglasses or regular glasses.
Oh, that would have that built in.
Yeah. So people often say, oh, do I have to wear sunglasses? And the darkness of the glasses actually matters less than the glasses blocking UV light, which essentially all prescription glasses are going to have UV light protection in them. So anyone wearing any type of prescription glass is protected. And even, you know, most off-the-rack sunglasses will have it too. Usually they'll have a little sticker on them that says that they block the UV. So just to look for that.
And while I'm thinking about sunglasses, there is such a price range, you know, from $8.99 or something up to, you know, hundreds of dollars. Do you need, for good quality protection, do you need to get over a certain amount?
Yeah, not necessarily, no. As long as they have UV protection from an eye health standpoint, any of those sunglasses are fine. You know, lenses that are polarized may give a little more improvement in kind of the reduction of glare, you know, off, you know, cars, or if you're wearing them out on the boat, you know, the water. So they're going to give a little more improved kind of darkening effect.
So that's when you're look for UV, UVA, and B, and then polarized also.
Yeah, and the polarized are going to be maybe a little more effective, but from an eye health standpoint, the UV protection is the most important.
Okay. Well, that's good to know. Let's shift. Macular degeneration. I don't know if more and more people are getting it. That's a question for you. But I hear a lot about it lately. And again, is that inevitable for people, or is there something people can do to prevent that?
Yeah.
And what is it first?
Sure.
Let's start with the definition.
Yeah, so macular degeneration is a problem with the retina. The retina is the layer of cells that lines the inside of the eye. It's essentially like the film in the camera of our eye. And in macular degeneration, those retina cells degenerate, or sometimes we'll say atrophy, or that layer will kind of thin, sometimes to the point where there's no retina there. So it's like you've got a hole in the film of your camera, so you just don't get a picture in that area. And there are different forms of macular degeneration that can develop. The full name of it is age-related macular degeneration. So it really is, again, a disease of aging. And I think we are hearing about it more because we live longer.
Sure.
So we just have people who are getting higher in age, and therefore macular degeneration becomes more common. As far as, you know, what are the risk factors or the things that make people more likely to get it? Because not everyone necessarily gets macular degeneration, even if they live to be over 100.
Oh, okay,
so
that's good to know.
Unlike cataracts, which everyone does get, macular degeneration is not like that.
Okay.
But having a family member with it does seem to increase the chances. We know there's a genetic link to macular degeneration.
I was curious about that.
Yep. Although having the genetic marker doesn't necessarily mean that you'll get it, so it's more complex than just that you have this gene problem necessarily.
Okay, that's interesting. About what percentage of people who are elderly end up getting it? Is there any number that's in your mind in terms of 25% or, a percent?
Yeah. That's an excellent question, and I actually don't know that number off the top of my head, but I will find out and let you know what.
But it's not uncommon, we know that.
Yeah, but yes, from a population perspective, I don't know that number off the top of my head.
In terms of preventative ideas for that condition, age-related macular degeneration, what can people do?
Yeah, so if people have especially a family history and they are looking for the ways to best support their retinal health, I tell people a diet of leafy green vegetables, and if people are not vegetable people, which not everyone is, just taking a daily multivitamin. So it's really just making sure your retina gets the nutrients that it needs.
Okay.
And just having routine eye exams for health. So if there are any early changes, they can be identified and monitored. There are some kind of exciting new treatments for macular degeneration, and so it's making sure that if there are people that are eligible for those, we can identify them and be able to offer them what's available.
I remember talking to an eye doctor probably 6 or 7 years ago who told me there is some really exciting possible future treatment related to stem cells and macular degeneration. Is that still the case?
Yeah, so I think stem cell therapy is very exciting and probably a little further down the road. There's, for repair of the retina, I think the exciting things are stem cells and then some genetic therapy or modification in people who have types of inherited retinal disease. So that's different. It happens in younger people, but the thought is that we might be able to apply some of those concepts in the future to the similar kind of atrophy that can happen in macular degeneration. I think we're pretty far out on that. There are different kinds of macular degeneration.
Right, mention, because there's wet and there's dry.
Yeah, and the dry kind is pretty much everyone starts out dry, essentially, which means that these little deposits develop under the retina. They're kind of the first sign that there's a problem with those cells. And then the retina thins or atrophies over the top, and that's when you start to lose the cells and the vision in that area.
So are there like leaky vessels? Is that part of it?
Exactly. So if abnormal blood vessels form under the retina, these blood vessels are very fine and they leak blood and fluid. And when you get that fluid in the retina, then that's called the wet kind.
Oh, so prior to the leaking, though, it's called dry. Okay. And which one? I hear people saying, oh, I'm so thankful I have the wet or the dry. Which one is the better one to have? It would be the dry, I'm assuming.
Probably for the most part. And we say that because the dry kind is very slowly progressive, meaning it can get worse, but it gets so very slowly over time. In the wet kind, or when people first develop the wet kind, they'll get a more sudden change in their vision, and it will become very blurry or kind of wavy or distorted. So like if they were to look at something straight, like a door frame, it'll have a bend or a curve to it, and that's a sign of that fluid collecting under the retina.
Okay.
And so the wet kind can be more impactful on vision, but we don't, although there's new exciting things coming, traditionally we haven't had any really specific treatments for the dry kind, except for sort of more support of the retina with eye vitamins. Whereas the wet kind, there are medications that can be injected into the eye that help those blood vessels to go away.
And that, she sort of glossed over the word injected, but really, it's people get shots right into the eye, don't they?
They
It
do.
sounds, if you haven't talked to anyone who's had to do that, it sounds almost impossibly unnerving, we'll say. But people say it doesn't hurt all that much. Obviously, you deaden the eye.
Yeah. So when I identify a patient that has new wet form of macular degeneration, I'm usually referring them to a retina specialist, and they're the one that does the injection. But yes, I always tell them, all right, they're going to be treating you with an injection in the eye, and that sounds bad, but the patients all come back and tell me it's not that bad.
Yeah.
It's quick, the eye is numb, and the experience is, for most people, kind of no big deal. Again, one of those things where it's much more anxiety provoking beforehand than afterwards.
That's really good for people to hear, because I think it does sound like something a person maybe would even be so afraid of that they would say, I can't do it, which you don't want that to happen.
Correct.
Yeah.
And I also tell people those injections, again, although it sounds so intimidating to have done, that medication is the closest thing we have to a miracle drug in ophthalmology. So those injections have been around now for many years, but before they came out, people inevitably went blind from wet macular degeneration, and now they don't. Now they get these treatments, their vision improves and gets better. Nothing is perfect, so people certainly can still lose vision from macular degeneration, but it's not inevitable like it used to be. So we can get people seeing better.
There's a great payoff for believing your doctor and trusting that it's not going to be all that bad. That's wonderful to hear. Well, then we come to the third biggie in terms of a disease, glaucoma. How do you define glaucoma, Amy?
Yeah, so glaucoma is damage to the optic nerve. So the optic nerve is the nerve that connects your eye to your brain. So as we're talking about cataract and the lens of the eye, the lens focuses the light onto the retina. The retina is the film in the camera that senses the light. And the optic nerve would be your digital camera sending it to your computer, right? Your digital camera cord. So damage to the optic nerve, again, means that you can't send that light signal back to the brain. And damage to the optic nerve in glaucoma happens typically from high pressure inside the eye.
Okay.
And that high pressure causes people, first with glaucoma, to have trouble with their vision kind of way out to the side, off to in the periphery, which we don't necessarily notice on a daily basis.
You wouldn't.
And so that's where glaucoma can be kind of a sneaky disease for people.
And what about prevention for glaucoma?
Not really a whole lot we can do, whether it be for diet or lifestyle, to prevent glaucoma. That's one where going in and having routine eye checks, every year to 2 years, if your eyes are otherwise healthy, is a good idea, because that's one where I look at a patient's optic nerve and I say, oh, your optic nerve looks a little suspicious, that maybe it's having some damage happen. Or they'll come in and, as part of what we always check for people, we check the pressure inside the eye.
Right.
So if their eye pressure is measuring elevated, that's another thing that makes us look more closely for glaucoma.
And how common is glaucoma?
Also relatively common. It's another disease that glaucoma really can happen at any age, including there's rare forms of congenital glaucoma that babies can be born with.
Okay.
But it's another disease that's most common as people get older.
Okay, so the three are then the cataracts, the macular degeneration, and glaucoma. This makes me think an annual visit to the eye doctor is a good idea. Do you recommend that for all ages, or just from a certain age onward?
Yeah, so personally for my patient population, I usually say kind of, 60 and above, a yearly eye exam is a good idea.
60?
60, yep,
Okay.
and above. A yearly eye exam is a good idea. There may be exceptions to that, but at
What about
minimum.
earlier?
Yeah, so 50 to 60, I usually say about every other year is fine.
Okay.
And then, 40 to 50 every 2 to 3 years.
Oh, okay.
And probably similar for
The
below
under-
40, but
Under 40.
well, I would say most young people with healthy eyes come to the eye doctor mostly intermittently unless they're having something
Right,
else that's being
right.
monitored.
In terms of just a few, we've only got about 3 minutes left, but diet, you said leafy green vegetables, that's got to be a good recommendation for all eye kind of care, right? What about any thoughts on screen time for both kids and adults?
Yeah, so for kids, there are specific recommendations for screen time from it's American Academy of Pediatric Ophthalmology and Strabismus, and they're pretty stringent. So kids less than 2 years of age, it should be essentially 0 screen time. And kids 2 to 5 years of age, they say 1 hour a day, which as a parent of a 1-year-old and a 4-year-old, that can be difficult sometimes.
Yeah.
But the reason for those recommendations is that we're seeing a population-wide increase in nearsightedness. And it seems to be that kids' eyes can be influenced by looking at things up close all the time. So essentially their eyes adapt to that and they become more and more and more nearsighted.
What about kids who are, elementary and above high school, and then through high school, and then into the college years too? I mean,
Yeah.
screen time for those kids would even be more intense, I'm guessing.
Yeah, probably more intense and they're going to do it more, but it doesn't affect eye development to the same degree
Oh, okay.
because their eyes are really mature at that point.
That's good to know.
So they might have issues with eye strain or other things, but they aren't doing any particular damage to their eye.
Well, we've suddenly run out of time. I could ask you all kinds of questions and we'd go on and on, but thank you so much, Amy, for coming
thank you.
down and informing me and all of us. It's been great, and appreciate it so much. We'll put her Southdale Eye Clinic contact info on the screens so people can track you down. But thanks again, and thank you for joining us tonight. I'll see you again next week, hopefully. Bye-bye.